Thank you very much indeed. I think my talk follows on very closely to Lunette's work, actually. There we go. The question that I like to put to you, can we actually measure MET? Or more broadly speaking, the rapid response system, and in my case, for children. And I'd like to tell you about what we tried here in Victoria. I want to talk about the Victor Metrics project. I have a disclaimer too. I feel a little bit like an imposter because I'm but a collaborator in this project. This project is sponsored by Safer Care Victoria, our statutory body that's been set up to really substantially improve safety and quality of medicine and nursing in Victoria, the way we look after our patients. It's really led by the inspiring Sharon Kinney, by Jennifer Sloan and Annie Molden, who are driving this project throughout the state of Victoria. But let me start by introducing our hero. This is our local hero. We call him Victor. And Victor stands for Victorian Children's Tool for Observation and Response. And what it is really a track and trigger chart that was developed in Victoria, very similar to what's in use now in tertiary children's hospitals throughout the world, age-related track and trigger charts that prompt nursing and medical staff to react to vital signs that are outside the normal range. Now, if you're training in pediatrics in 2016, 17, 18, this is what you grow up with, and it's just business as usual. However, many of us still remember when these charts only came in a few years ago, and they were a real game changer. They changed the way we looked at the deteriorating, how we identified a deteriorating patient. They changed the way we manage children and adults these days, in fact, right from presentation to hospital throughout discharge. Mainly for the better, I'd like to say, although we do have some concerns, as Lynette highlighted, are we doing too much? But ultimately, this is business as usual in hospitals throughout Australia now. When you talk to people from the Australian Commission of Safety and Quality in Healthcare, they tell us we need to evaluate what we're doing. And that might seem confronting if you are immersed in a tertiary hospital and have been using this tool for what seems like an eternity, but in actual fact, it raises some really profound and interesting questions which we're only beginning to answer. First of all, from a pediatric point of view, what is the actual epidemiology of MET? I happen to work in an organization, Monash Children's Hospital, where every month we look at our MET data. And still, 2 years in, we're talking about what should we actually look at. Is it the total number of calls? Is it the calls per 1,000 admissions? Or is it separations? Is it code blues? Is it MET? The answers sometimes seem less than straightforward. You go a little bit into the so-called periphery, i.e. the metropolitan and regional hospitals, where in fact more than 50% of pediatrics happens. And that is an even more challenging question. How do you measure the activity around deteriorating patients when your patients are a minority that your health system is actually not really designed to cater for? It's designed to cater for the 95% of the other patients, the adults. Take that a step further, that what happens during a MET, what happens at Monash Children's Hospital might be different as to what happens at the Royal Children's Hospital. And it's very different to what happens, for example, at Frankston Hospital, a large regional centre south of Melbourne. And are we actually measuring the outcomes? And what should we measure? In pediatric intensive care, fortunately, mortality is now so low that it has stopped being a useful measure. In other words, children fortunately don't die very frequently. It also means that we cannot use death as a sensitive indicator of how good we are at our job. We need to look at other things. And then following on what from Lynette said, a question that we ask ourselves, what is the right MET dose? In my organization, we've just gone from about a dozen emergency responses in children a month to now almost 50. Some changes we have made, maybe it's winter. Is that good or is that bad? The additional resources and time required, does it actually provide value to our patients, or does it rather distract us from the other important work that we're doing? So these are quite weighty questions, and we found, looking at what we know from looking after kids in Victoria, we don't have an answer. So can we actually measure MET? Prior to this project, under Sharon's leadership, we actually looked at what's happening in Victoria. We found the data collection, particularly around pediatric patients, but I believe the same is true for adults. It's actually very diverse throughout the hospitals. There are diverse databases, there are diverse data points that we collect. And many health services used adult tools for collecting pediatric data, which means that we're probably losing some valuable information for our patients. The primary and aim and the starting point of the Victometrics project, therefore, was let's start with standardizing data collection. So we spent quite a lot of time getting together an expert group, regional, metropolitan, tertiary pediatricians, intensive care physicians, and senior nurses, and we agreed on a set of data that we thought would give us a good picture of what's happening around emergency responses for children. And following on from that, we had a very interesting and detailed discussion. Can we develop that into what we call metrics, meaning condensing and analyzing the data to create useful measures so that we can answer all these tough questions? We had 11 pilot sites throughout the site using a single data form, and this pilot project ran over 5 months from December last year to April this year. We collected data on 286 cases. The adult practitioners amongst you, I beg forgiveness. The pediatricians and pediatric nurses will know this is actually quite a large number. And after we acquired the data, we went back to the participants, the nurses who did the bulk of the work of collecting the information, but also the doctor said, has it been user-friendly? The answer was yes. Do we find it's useful? Is it sustainable in terms of workload? And can we interpret it? And I want to show you briefly, this is the data form. You may say it's nothing earth-shaking, but when we go back and see what's happening in Victoria, this is actually a real novelty to have a standardized data collection tool that tells us whether you're on the Mira River or in the heart of Melbourne, we get the same data and information from you. So this has been a real game changer for us running this pilot project. And just by way of example, a few of the data collections that we get. If you're working in a tertiary hospital with a mature rapid response system, this will not surprise you. But even for us at Monash Children's, we actually tweaked our system, and I'm sure for many people in metropolitan hospitals and rural centers, this is actually some real useful data to compare yourself against your colleagues in similar centers, in the tertiary centers, and plot what's happening with your deteriorating patients. When are calls made, time of day of the week, time of the call, what happens to children after the call, and why are the calls actually made? Can we see trends? You see, one of the things that we subjectively know in my institution, but it was good to see that's actually a feature throughout Victoria, is that the majority of calls are made because of tachycardia. This is really interesting for me when I teach my residents. Tachycardia often is what I call leads to diagnosis of convenience. It's probably just the fever. It's probably because the child's crying. It's probably because we're disturbing them. When the diagnosis of horror is this could be septic shock, and the child is in compensated shock. And these are really interesting conversations we now can have with our nurses and our junior doctors. So what did we find when we looked at how well did the project run and evaluating the actual running of the project? Data acquisition was very good. So we're actually very happy with the tool that we developed. Our nurses and doctors said this is not hard to collect, even though it's quite a lot of data points. We found that we didn't really want to rationalize and omit data points, so we thought all of that was relevant. It was found to be very comprehensive. There was quite a drive to include more data, important questions as to was there delayed response, did we miss met calls. However, at this stage we feel that would increase the burden of collection throughout, particularly the not so well-resourced centers, and we'll set no to that at this stage. Is it a sustainable effort? And the answer is absolutely yes. It's definitely doable, and we find that this type of data collection could happen in any health service. What did we actually find in terms of data? Well, the numbers, unsurprisingly, vary greatly by site. The tertiary centers, the largest center had about more than 100 rapid response calls a month, whereas the smallest one only had 1. The median duration of the team attending a deteriorating patient was 20 minutes. And again, just by way of samples, up to 1/3 of calls, emergency responses were necessary in children who had just been transferred from critical care areas, in other words, theatres, emergency department, ICU. That raises some interesting questions, obviously. Are we too quick? Do we not preparing them well enough? Unsurprisingly, 83% of our patients had breached at least one criteria that our local hero, the Victor chart, has given us. That's the purpose of the tool. It also means that about 20%, almost 20%, of rapid response calls were triggered not because children were in the red or purple zone. And in our system, staff are allowed to modify MET criteria, and that happened in about 6% of patients. We had 3 cardiac arrests. That's obviously something that we want to avoid. And in about a quarter of, or 20% of children, we detected significant interventions. Significant intervention would be an increased level of care, such as instituting high flow, giving fluid boluses. So not nothing. And interestingly, 13% of the patients then transferred to a higher level of care. That could be admission to HD or ICU in the same hospital, or for a rural or regional center, it may often mean transfer of the patient to the tertiary hospital. Very, very interesting data. What does it all mean? Well, that's the really, really difficult question. We find that at this stage we're not actually able to benchmark. I cannot tell you what the right dose of MET in the Victorian health system is. And that's one of the very important questions that we're hoping in the fullness of time we can answer. However, what we think the really great value of this program is that we can now start talking the same language. That means that health services that are like, say, Frankston Hospital, Northern Hospital, the outer metropolitan area, the rural hospitals, the tertiary children's hospitals, we can compare ourselves, and we're having a much more educated conversation. So the recommendations that we made at this stage is that we would like to collect the data and calculate these metrics that we have developed statewide on a regular basis. We want to do this digitally. Again, one of our surprises was that the various health services use anything from an EMR to the statewide risk reporting tool to simple paper tools that sit in the pediatric office of the ward. And we would like to share our data statewide in regular forums once or twice a year. Ultimately, the holy grail that we're trying to find is to give us the answer to the important questions. What is the right emergency response to a deteriorating child? Can we tailor that to the health service and the situation of the health service? It's most likely to be very different in a regional hospital versus a tertiary children's hospital. And can we measure that the response that we provide at quite some expense is actually reaching the patient and is the best that we can provide? And with that, I'd like to thank you and once again acknowledge the people who led this work. Thank you.